and patient and customer perspectives. He's worked extensively, especially in developing the clinical value compass and whole systems measures to assess health system performance. Our second speaker and our pinch hitter, thank you very much, is Matt Stiefel. Did I get that right? Those of us with IE and EI in our name, we're sort of a little club. He directs the Center for Population Health in Kaiser Permanente's Care Management Institute. He was a fellow with the Institute for Healthcare Improvement and continues as a faculty member for the Triple Aim. Prior to his time at Kaiser Permanente, he was a policy analyst on the Carter administration's domestic policy staff and the U.S. Department of Health, Education, and Welfare. And finally, the man who does need no introduction because he was already introduced to you earlier, Craig Jones from the Vermont Blueprint for Health. So, Gene, I'm going to turn it over to you to start.
Very good. Thank you. Well, thank you. It's a real pleasure to be here. And I appreciate Craig and the committee giving me an opportunity to talk about accountable care in the three-part aim and lessons from Amory Lovins and Wayne Gretzky and the Gretzky group, along with Jim Weinstein on the way. So I'll move pretty quickly, and I hope you'll get a sense of why I think this moment is so important to get the measurements right. So we'll start with a riddle from Amory Lovins, an energy expert. How is a kilowatt hour of electricity like a day in the hospital? Nobody wants either.
I don't know. How is it?
Hot showers, cold beer, better care, better outcomes, lower costs for patients and communities. And his emphasis is always on end users and value to the end users. And as we start to think about accountable care and where that's going, we want to be skating to where the puck is going to be. The great one, Wayne Gretzky, when asked what his secret was, how could he score so many goals? He said the secret was skating to where the puck's going to be. And where will the puck be for U.S. healthcare in 2015 or thereabouts? What would end user value look like to patients, to consumers, to the communities that we're taking care of? So this is fresh off the press. Oliver Wyman, the big surprise: 25 to 31 million Americans currently in ACOs. Is it a flash pan phenomenon? I don't think so. It's amazing at how quickly this is moving. There are over 200 ACOs in the country that have started. There are approximately 30 pioneer ACOs. Things are changing incredibly rapidly. And my sense is that this is where the puck is going to be. And it is, in many senses, my sense, our best hope for meaningful reform and innovation if we get the measures right that promote innovation that's rapid and promotes a very patient-centered, value-based approach. So I'm at Dartmouth Hitchcock as well as at TDI. We're a Medicare ACO, and we're as rapidly as possible converting all of our contracts to be ACO-like. And what would value look like then? So we have, let's say, 50 million Medicare, 50,000 Medicare patients attributed to us. What's their initial health status? Some of them are quite healthy. Some, they're all at risk. Some of them are quite healthy. Some of them have simple chronic problems, some complex chronic, some end of life. And some are going to go into our health system from their homes. And there's an entry process, an assessment process, a diagnosis, shared decision-making, hopefully, treatment, follow-up. And the question is, how has their needle moved one by one? What's their change in disease status? What's their change in functioning and risk status? What's their experience of care against their hopes for good care and their need for good care? And what are the costs? So we start with an initial health status of an individual with heart failure, for example, or a newly diagnosed cancer patient, and we measure these important things at baseline. The process of care goes forward, and the question is, so what's the new health status? and at what cost, and what has the experience been like. And we wish to design and measure our performance in that manner. So, how would you possibly do that? How would you possibly have a system of measuring outcomes, experience, and costs that was useful for patients and clinical teams in real time as care is delivered, as well as useful for improvement and for contribution to registries, and perhaps even for research, and certainly for payment? This is Jim Weinstein, so some lessons from Jim. In 1998 or thereabouts, the Spine Center was started. It was an out-of-the-box innovation. It was patient-centered, no more roaming around, one-stop shopping. Everything was in one place. All the specialists were there. All the rehab people were there. No more roaming around. Back to work, back to play, one back at a time, very personalized. And a new information environment was built that made extensive use of patient-reported outcomes data. And this system that you'll see was then generalized to 16 other clinical populations at Dartmouth Hitchcock. So imagine now that, that I'm going to the spine center and I have low back pain, and I decide to go there after referral from my primary care doctor. There's an orientation to the patient-reported outcomes information, and there's an initial workup and plan of care. And based on that plan of care, I could go into an acute care management track or a chronic care management track or functional restoration or perhaps palliative care. And we're looking at how the person is at initial time in a scene for the initial plan of care. And I can provide that data at home or with a touchpad when I show up. And this information on me informs my plan of care, and it informs how well I've done over time. So the data is being fed forward each time. You'll see that in just a moment. It's being fed back one by one, and for an improvement registry and for public reporting, as well as for research. So this is one-page care or same-page care. This is what Jim Weinstein would see if I were a spine patient. And we can look at my functional status, 2 points in time, getting better on both the physical and mental. We can look at my disease burden, getting better here. We can look at how my pain is doing, my experience against the outcomes that I desire, symptoms and prior history and risk status. It's all there, and this becomes the basis for getting a plan of care that matches me and for involving me and engaging me in my decisions and evaluating the effectiveness of my treatment. And Jim Weinstein would say, I can't be a good doctor any longer without this information. It's so vital to me. And we heard earlier about the importance of the data being valued by the clinician to be actionable by the clinician, and a new mentality of using this kind of information. So this can also be used prognostically. So this is people like me. So I put in my calculator, my age and gender and some symptoms, and this is based on historical data. If I don't get surgery and I have degenerative spondylolisthesis, what are my outcomes over time? Or if I do get surgery. And so again, this is used for informed decision-making at the individual patient level. This is sport trial data, so 13 other centers around the country followed patients now for 6 years. They either had surgery or did not have surgery. And you're starting to see the value using a few simple measures, a few core measures, for patients undergoing surgery in blue and patients not having surgery in yellow. And this is disease burden, symptoms, et cetera. Much greater improvement in both groups after 2 years, much greater improvement in symptom burden with surgery. Physical function, much greater improvement with surgery, but both improved remarkably. These are huge changes and improvements. Perceived health benefit favoring surgery, but both felt a health benefit. This is total cost after 2 years, direct healthcare expenditures as well as indirect social cost. Looks like for the average person, better results, better experience of results at greater costs. So we have a trade-off, and somebody mentioned earlier, how about cost effectiveness? Well, you can start to look at that in terms of quality adjusted life years, surgery versus non-surgery, and at what cost. So it's meant to show how you can start to use information at the individual patient level in real time and over time, and how it can improve decision making, and how it can be aggregated up to see how a population of people are doing over time. Oh, by the way, this kind of information is on the website at Dartmouth. So it is publicly reported information, outcomes, experience, and costs since about 2002. So there's the issue of end user value. What are my outcomes as an individual? What are my experiences as an individual? What are my costs of care as an individual? And how might we measure them in real time and be useful at the frontline level and the patient level, as well as useful for all these other levels of the system, the practice for improvement, the health system, a set of health systems. So this goes to the issue of, so what would you measure if you started to figure out how you might create an infrastructure? And we're playing with Gretzky, looking at what would the data look like in 2015 for an accountable care organization that was actually measuring the triple aim? And how will we collect that and use that information? And what would the data elements be? So this is a paper that was published recently in the BMJ. And this was using the core measure idea and using the IOM quality aims, as well as the triple aim, and looking at different foci. And so this brings forward, in a sense, some of the whole system measures that IHI has done. And these people are from an informal group, the CQO Roundtable. So it's organizations like Mass General Hospital and Ascension and Intermountain Healthcare and Mayo and Virginia Mason and Kaiser Permanente and IHI and Centera and Sutter Health System. And they're saying, you know what? If we could have a parsimonious and balanced set of important measures for our health system, that would be much better than right now at Dartmouth. We have literally over 200 quality measures from our 5 major payers. Mass General 2 years ago had over 120 measures from their major payers. And it cost about 1% of net revenues to collect and give that data back. So what if we started to have a core set of measures? And you'll have a handout, if it's useful, in the breakout group that has this table on it along with footnotes as one example of some people's idea of a core measure set. This is now taking us to what we've learned from, I'm going to finish up quickly now, the Gretzky group that was led by Janet Corrigan and Elliot Fisher, and was a multi-stakeholder group, these organizations and more, that were in discussion for 18 months and held a 3-day meeting last October to try to answer the question that we're facing here. What would a core metrics look like for accountable care in 2015? And that would focus on patient-centered value, be longitudinal, cross-cutting, address the 3-part aim. So we use this longitudinal framework that we've heard mentioned earlier, that it is people at risk, it's people with an incident condition and following them over time, or with a chronic problem and following them over time, and getting the right measures at the right point in time. So this is the punchline slide for the idea of a thought about core metrics for accountable care, fit for the future. Difficult to do today, but perhaps fit for the future. And so we start with a value equation, outcomes and experiences in relationship to per capita costs over time for individuals and for populations and subpopulations. Let's look at outcomes. Everyone has a risk status. Let's measure that. Everyone has a functioning status: physical health, mental health, including symptoms, role function. Can I work? And some people have diseases and conditions. So health outcomes, it's looking at the transitions in states, in risk, in functioning, and in disease. So those would be three core categories. Patient experience, many things are important here based on national work done by Picker and National Partnership and others. These might be four of the most important aspects of core measures: access, communication, coordination, shared decision-making, and patient engagement. And we've heard before from George and others, per capita cost, expenditures, and resource use. So that would be an idea about simple, powerful, core measures aligned with the three-part aim. And the details behind actual tools to measure them are on this handout that you'll have available to you. So end user value, outcomes, experience, costs, useful for individual people, patients, and populations. The idea of core metrics that can follow people over time, and some examples of how that might be done. Thank you.
Well, that sounds good. Let's do that. Yeah. So I'm kind of glad I'm going today instead of tomorrow, because the longer I waited and the more speakers before me, the less novel things I had to say. So, but I think there may still be a few. I was going to be talking about implementation tomorrow, and they wanted me to talk more about content today. But I think that the implementation questions are still very important in the context of the content. And what I'm going to do is talk a little bit about the experience and the implementation issues that have arisen over the past 5 years in our work with the triple aim collaboratives at IHI, with over 100 organizations of all shapes and sizes from around the world. And a few of them, and I'll go into a little bit more detail on each of these. The how do you define the population question has already come up today. It's a problem that's largely unique to the U.S. Despite the rapid growth of ACOs. There are still large parts of the U.S. healthcare system that take care of patients rather than people, so the population definition is still very difficult. Linking process and outcome, population and project metrics is at the core of IHI's model for improvement. It's especially challenging, though, with the triple aim, because a lot of the outcomes that we're talking about are very far downstream. And then it's come up already twice today about how do you combine the three measures into an overall measure of value, and I'll say a few things about that. In population health, I think one of the biggest challenges comes back to this connecting determinants and outcomes. I think especially challenging with population health. This has been the domain in the triple aim collaboratives that has been the most difficult, in part because the outcomes are very far downstream, and in part because healthcare has a relatively minor contribution to those outcomes. In care experience, it's the challenge is not so much the absence of measures. I think it's the overabundance of measures. This is not an exaggeration. Joel Hyatt can attest to this. We used to take to our board of directors 300-page binders of quality measures. I think that was kind of intentional, just to say, look, we've done a really good job here. You don't really even need to look at it. Until they kind of wised up and said, wait a minute, we can't make sense of this. And so I think the challenge is to organize these into a framework, a system that makes sense in looking at measures of care experience and cost. It hasn't come up yet today, but I think that one of the big challenges is from whose perspective. And I think you have very different notions of cost when you're looking at the supplier perspective or the health plan or intermediary perspective, the purchaser consumer perspective, or the larger community. So let me go into a little bit more. Steve Teutsch's paper in support of the NQF Population Health Steering Committee, I think had the best framework for looking at population that I've seen, starting with this notion of total population from a geopolitical perspective. But then that total population contains within it all kinds of subpopulations. Subpopulations from healthcare delivery systems, by demographics, by conditions, by purchaser groups. And the challenge is in rolling them up. And I think that the idea here is that total population is the union of all of those myriad subpopulations. Over the course of the last 5 years in the triple aim collaboratives, there's been this steady progression in moving from subpopulations to a broader view of a geographic population, because I don't think you can ultimately achieve the triple aim without a broad multi-stakeholder coalition and a broader definition of the population. Oops. And so this is one version of, there are many, many models of the determinants and outcomes of population health. This serves to I think, emphasize that, one, these relationships are complex, and also that historically in healthcare, we've kind of focused in the very narrow middle of this diagram, that we can measure things like physiology and disease status, but we've not done a very good job at all, and we've talked about it a little bit already today, in measuring the downstream outcomes as well as the upstream determinants. And I think, and the challenge is how do you make those connections? One thing that we've found fairly useful is using models to make those connections between determinants and outcomes. At the macro level, we've been using this model developed by the Rethink Health group and Bobby Milstein and others, where they're looking at the whole system and looking at the broad community perspective about how you can improve the triple aim by looking at all of these levers. At the micro level, we use in KP Archimedes quite a bit, which is very differently, if at the individual level, looking at the physiologic factors, disease factors, and then relating those to downstream complications and outcomes. So I think an important sort of methodology for how you connect the determinants and outcomes. Here's just a little smorgasbord of examples of metrics of population health, and you have in your materials a lot of stuff from organizations about how they're measuring. This is from organizations, real organizations in the Triple Aim Collaborative, and the kind of metrics sort of related to that schematic that I showed you. Here's one from KP that I'm involved in our Colorado region, motivated by the new annual wellness visit for Medicare. We've developed what we call a total health assessment that's integrated with our member portal and electronic medical record. That's pushed out to members either through the member portal or IVR telephone. That information goes directly into our EMR. And then there's a lot of work done prior to the member ever coming in for care, based on the proactive office encounter developed by our Southern California region, and Joel Hyatt is here, where this was pioneered, where a great deal of the work is done before the member even comes in for the visit. When they come in for the visit, they're given their personal prevention plan. The physician reinforces that information, and then a number of follow-up activities take place. This system has been very successful. So far in Colorado, about 60% of the members who have done this have had one or more positive triggers for things like urinary incontinence and falls and frailty and mental health issues. And these are issues that likely would not have shown up during the course of a short office visit, and one of the important factors in becoming a 5-star Medicare organization. Appropriate being at an IOM meeting to talk about the framework that we've found to be useful for care experience, using the 6 aims as the process kinds of measures, and then as for outcome measures, or the patient-reported measures, so that we can hear directly from Gilbert about the things that matter to him in the overall experience of care. Here are, again, some examples from various triple aim collaborative members about the kinds of care experience measures that they're using. I'll just drill down a little bit, and I know you can't read this, but it's KP's version of a quality metrics dashboard built largely around the 6 aims, so that we have care experience measures and safety measures and resource stewardship measures, equity and service measures. We track them at the national level and compared to over time and compared to outside benchmarks and across the regions. And then for each of these, we can drill down deeper and deeper by both geography and component measures. One thing that we found very valuable in constructing this dashboard is the notion of composite measures. And I know that there's a lot of controversy about how you roll them up and values judgments embedded in those composite measures. But it's been very valuable for us, especially with the ability to drill down. And it's focused attention in the organization, for example, on improving service quality. Cost, I mentioned that the challenge was from whose perspective, and I think that it's one that we haven't paid a lot of attention to. But you can see from this schematic, from the supply perspective, it's the cost of production. And then that cost of production plus providers' overhead and margin is the cost faced by the intermediaries or health plans or insurance companies. And then their cost plus their margin is the cost faced by purchasers and consumers, or as we're finding increasingly that they're bypassing the intermediary and because of their margin. And then sort of the broader community perspective, as we've talked about, includes this public health, and you can broaden that to social services expenditures, as well as indirect costs borne by purchasers, including presenteeism and absenteeism. And all of those different frames on costs give you different answers. So it's important to articulate from which frame we're talking. Here again are some examples from the triple aim organizations, and you've heard about the health partners metrics and the NCQA measures as well. I won't have time to talk about this. This is from a Medicaid managed care organization in Portland, Oregon, Care Oregon, where they have built this learning system and connecting the population outcome measures to very specific projects across the dimensions of the triple aim. Here's this what Maureen referred to earlier about the idea of value, and you can argue that the relationship. First of all, that I think Don Berwick and Tom Nolan very consciously avoided this question about how you roll them up in the original triple aim article, because it's a big challenge and it depends on your values and perspective. But of course, it's necessary because they're related. The extreme example is cost. If you just wanted to minimize cost, you could just spend nothing on healthcare. But of course they're related, and as Maureen mentioned, this relationship between experience and cost might be in the efficiency domain between population health and experience, and the effectiveness or comparative effectiveness domain. And the relationship between population health and per capita cost might be in the cost effectiveness domain, and this is where, in health services research, you see a lot of work, not so much in actual practice. And one thing that we might consider, and might consider in the breakouts, is a broadening of that notion of cost effectiveness to look at not just the relationship between health and per capita cost, but all three of the domains, so that quality adjusted life years, that quality adjustment includes the quality of care provided as well into an overall frame for the triple aim. And so this is this is, I think what was the term was embarrassingly parsimonious menu of measures used in the triple aim collaboration. I think it looks simpler than it actually is by putting it all on one page. But that's the idea, and perhaps this can be useful when we go into the breakouts about the framework used in the triple aim collaboration. And I think that's, and I'll just mention that this is a white paper that came out just on Monday, based on this material and that collective experience of the triple M collaboration over the past 5 years, and it's available through that link. So thanks very much.
Thanks again, Michael, and to the IOM for the opportunity to be here. I'm going to run through a little bit of a different angle on this, watching the presentations, as opposed to focusing so much on the measure types that we're using. I wanted to highlight actually some of the implementation challenges that we have, some of the practical things that we're running into. Let me just give a quick background to set some context. What the Blueprint is a program that's intended to lead some delivery system reforms across Vermont, and these are all components that are in place and being expanded across the state now, the medical homes, what we call community health teams, the payment reforms that support it, and then quite a bit of investment in infrastructure to support a delivery system reform, including a health information network, centralized clinical registry, a number of other data and evaluation systems and reporting systems, networks of community self-management programs, and then what we call fondly learning health system activities, which includes all types of shared learning forums and interactions, as well as teams of facilitators to help practices. So that's the framework that's going in place. And it's intended to build communities, and there's a lot of structure to how they work together, both of medical and non-medical providers. And working together, planning their community health teams, how they're operating, beginning to build more of community organized systems of health services. And there's a big emphasis on more holistic health services, and that becomes important when we talk about the measurement and the health information, and not just the healthcare realm. And we talk a lot about that normally in conferences. I'm going to focus on the bars at the bottom, and particularly the difficulty of putting together the data systems that allow us to do the types of measurement that we're talking about. And we've had an interesting dynamic here. These teams are rolling out. They're maturing at different rates. The medical homes are rolling out. The ecology, if you will, for primary care and these health services is changing in different areas of Vermont at different paces. And the red dots are, as of last October, where medical homes are, and we're now up to about 110 or so, and we'll keep growing. And there's about 400,000 patients with exposure potentially to medical homes and community health teams. And most importantly, and what I really wanted to emphasize before shifting over to the data questions and the measurement systems, is in many of these communities, particularly the ones operating a little longer, where they meet regularly, work together, the culture is changing. And there's nurses, social workers, dietitians, public health district office directors, the AAAs, there's mental health providers. There's a whole network of people working together differently. It's evolution, takes time, but it is happening. And we started to notice that culture change this year, and it was a very positive thing in many of the communities, and we got so interested in it, we even wanted to try and understand it in the context of a framework recently released in an IOM paper on the principles of team-based care. Many of these characteristics are emerging, and they're taking shape as a new healthcare environment forms. And it's very interesting, but the one thing we heard consistently across the state, everywhere, is where's the promise of IT? So there were new people working, doing things, looking for their health information systems to provide them the type of feedback we've talked about, timely access to information, the ability to respond to measures, and it wasn't there. And many, many millions of dollars are going into health IT and into these data systems, and it wasn't there. And that actually was creating quite a bit of animosity, literally, among the clinicians who see more money going into that than they do into the provision of actual services for people. And this is a real thing that is actually a threat almost to some of the success of healthcare reform. So let me just turn now and talk about those challenges, and hopefully this will contribute to the implementation discussion. It's certainly one of the reasons that I have such passion about this topic. We're not in an environment where we have a single organization with captures all its information in one setting, and you're able to produce the types of dashboards that you may at a Kaiser or in Dartmouth. We have lots of independent providers, lots of different EMR systems, different practice management systems, and just a whole array of different sources. So let's talk from the clinical side, capturing the information that may help you understand more about health, more about self-management. We started with a core data dictionary and a measure set. And that was put together with clinicians, taken from national guidelines, the things that we've talked about this morning. And the whole idea was that core data dictionary would help build out our health information network. Because otherwise, it's one thing to move a snapshot of a patient view from an electronic medical record around so somebody else can see it, a static PDF almost of a patient note. It's quite different to move data around and put it in a place in a way you can aggregate it, sort it, manipulate it, and use it for the purposes that we've talked about. So we thought the core data dictionary would help. And so the EMR, we have coaches, the EMRs are being updated, templates are being improved to capture data elements, interfaces are being developed against the data dictionary, the movement of that information through the health information exchange and into a central registry. And when we started producing reports, what came out was largely junk. The technical limitations, there was comments earlier today about the nature, whether there is or isn't technical limitations on this, they're extraordinary. The ability to capture these data elements in structured ways, and I can give you all kinds of scenarios, and maybe in the breakouts, some of these. The point being that if there isn't a core set of elements, and then most importantly, a reason for the technical vendors to use those, to build their systems to capture those elements, be able to export them, be able to move them, be able to ingest them, and be able to manipulate them. If there aren't the incentives in place for the technical vendors to make that happen, this becomes an incredible challenge. And we've created a process now, we call it an end-to-end process, literally site by site around the state, where we have everybody on board and we're having to work through the technical limitations so that street names don't end up in zip codes and so that deceased patients aren't coming out on outreach panel management reports and so on and so forth. Nobody owned that process. And part of it was because none of the vendors had core metrics to align around, nor certainly did their financial incentives incent them to align around those core measures. So the ability to use clinical data across settings, across organizations, can be driven by core metrics. It is also going to need the right incentives for vendors to organize around. That is one key, very practical limitation. And for instance, with Dartmouth and Fletcher Allen, the University of Vermont, our tertiary care center, forming a new ACO, they'll certainly have their electronic medical record information, but if they want to be able to manage a population across all these different settings, you're going to need some data source other than their own EMRs, in addition to their own EMRs, and the only way you're going to do it is by building out against core measures. It's a very key aspect of it. Another example, all payer claims databases. Sure, that is easier than the clinical data, but once you actually start trying to work with data from different insurers, format it, make it consistent, be able to walk through an end-to-end process where it's usable for comparing oranges to oranges, apples to apples, without a common data dictionary up front to build out how that data is taken, captured, ingested, and formatted. This becomes an incredibly difficult challenge. It's different when an insurer holds their own data or a plan holds their own data. Core metrics are critical for this. And again, the financial incentives have to be there for all to be willing to use those core measures to build against. These are challenges that are really critical to overcome, even if we don't have the perfect measure sets. So just a framework. If there were core measures 3 years ago when we started this, and if incentives, for instance, the stimulus funds that went into expanding the use of electronic medical records, meaningful use dollars, if they had also incented building out EMR systems that could capture the elements you need for core metrics, we would be in a different place right now. And so to me, that's one of the challenges and one of the real pressures for wanting to see this come to life. If you have core measures, you can have specific numerators and denominators. There we go. If you have those numerators and denominators, there are defined data elements that have to be captured. The defined data elements, then you'll structure your data capture systems, your exchanges, your storage systems to be able to hold those common elements. And if you structure that digital infrastructure driven by the core metrics, you can optimize data quality. And very importantly, if you don't have trusted and reliable data, none of the things that we're talking about, the use of the data, that's where it falls apart. So right now for us in Vermont, the only sign-off we have where our vendors get paid on the registry of the insurance exchange is when the clinicians at the source site say the data in the registry is trusted and reliable. That's the endpoint. And that type of financial interest has gathered the hearts and minds of people to work together differently than we had before. Without core measures across the country, it's going to be very difficult to be able to capture this information. So this is a last bit on a little bigger framework and how maybe we're trying to think about it and build out our digital infrastructure and the reasons why. There certainly are large numbers we know of established guidelines and measures, and the good news is there'll be a lot of work at trying to come down to some key set that are maybe good examples and composite measures that are meaningful. Those really should guide the core data dictionaries and measure sets that we use to build out our digital infrastructure, and there needs to be the incentives to do that for the different people involved. That guides your analytics and reporting systems that have to work across now multiple settings and independent organizations. If the quality is good, you get trusted, reliable, actionable information out of those systems. Certainly that is used for collaborative learning and ongoing improvement and team services in the communities, but it also then is available to guide ongoing policy reforms, payment reforms, which are in themselves will be dynamic as we begin to see the results. Without starting with those core measure sets and the key data elements, it's really hard to put some type of cycle like this in place. And so the technical challenges and the incentives behind the practical problems are also some of the implementation challenges are key to this. So let me just close out there and thank everybody for the opportunity. I'm looking forward to the breakout sessions. Thank you.
Thank you. Thank you to all of our panelists. We heard in this session 3 very different case examples of initiatives that had to think through metrics. They had to think about the factors that were going to drive, and principles that were going to drive their choice of metrics. They faced a number of implementation challenges. And I think it was really good to be grounded in these real world challenges before we go to the breakouts, although I think we have some time for questions before that. Let me just say a word about the breakouts so people know what they're transitioning to, and then I think we have time to take a couple questions as well. So everybody, we're going to break up into breakout groups again. We're going to talk about the 3 parts of the 3-part aim: care, health, and costs. So turn over your name tag. This is a little physical activity post-lunch. And you'll see that you have either a yellow, black, or green dot. If you have some other dot, call a doctor. Yellow means you're going to be with the health group. Black means you're going to be talking about health care. And green means green, of course, means you're going to be talking about cost. Someone has a sense of humor. So let me tell you what your rooms are. If you're yellow and you're doing health, you're in the Irvine Cove room. If your dot is black and you're doing healthcare, you're in the Huntington room. And if your dot is green and you're doing cost, you're in the executive dining room. In each room, there's a charge for each of the groups. It's in your meeting folder, and it'll also be in the room if you can't find it. But in short, each group is going to be proposing key metric categories to include in a core measure set. We'll need examples of metrics in those categories and an outline of the implementation challenges and opportunities to advance measurement on that dimension. Each group should nominate a reporter. Probably want to do that at the beginning and not the end, to report back on the group's deliberations to the full workshop. We're going to be back in this room at 4. We're going to leave here at 2, so you'll have a couple hours to do the breakout work. So now let me pause and invite anyone who has a question for our panel to come up here, but I just wanted to let you think about where you were going to. So Carolyn, good, we'll start with you.
Carolyn Clancy, ARC. So I have to apologize, Jean, I missed yours. Other stuff. What can I say? I missed lunch, so I was catching up. But Craig, I had a question for you, and I'm thinking about our colleague from EPIC and also Kevin, who I don't see here right at the moment. There you go. You know, I've certainly heard all the complaints about health IT. I'm sure that at an unenlightened stage of my life, I made most of them as well. I'm just kidding. My question for you is, as you know, your initiatives unfold and people get better at it, how articulate are they at actually telling vendors or others what they need? I mean, I just wonder about sort of a time phase delay in terms of, you know, actually they're doing a great job trying to catch up to what you told them you needed 2 years ago, which probably wasn't actually all that clear anyway. You know, so I'm just trying to think about how do we move forward on this front, because it's kind of shooting fish in a barrel to talk about the same old problems. And acknowledging it and recognizing it, I think, is really important, but how do we move forward?
Yeah, no, thanks. I commented on it a couple times. I think a couple straightforward steps would really help. One is that there are core metrics for people to align against, and number 2, that the financial incentives that are leading to the expansion of all these technical systems are linked to the tracking, exchange, and use of those core elements. If those 2 steps were in place, it would probably change the marketplace. So if clinicians, you're right, 2 years ago they had, probably still in most cases, have no idea what needs to be done behind the scenes to set this up to make it viable. But imagine if meaningful use dollars or payment reforms were linked to the tracking, exchange, and use of a core set of metrics. So I offered that up a couple times in there. I believe that would have changed the marketplace. And one really good example of that is right now with ACOs. Somebody put out 33 measures and the whole world's stomping around trying to figure out how to measure them, collect them, and organize the data, because there's financial incentives linked to a set of metrics. So I think that's the...
Hi, Rob Green from United Healthcare. I like the idea of core metrics and simplified metrics very much. I wonder if, in addition, we have to think about, and it was alluded to earlier today, specialty and condition-specific measures, especially thinking about much of specialty care may not be population-oriented, so orthopedic procedures, ophthalmology procedures. Very quickly becomes a wide variety of outcome measures and other measures. So I'd be interested in your thoughts about approach to specialty care.
Yeah, I think a rule of thumb is, as I mentioned earlier, everyone has a risk status, high to low. Everyone has a functioning status that can be captured generically using really now great measures with the PROMIS measure sets. So PROMIS is to health outcomes as ARC, as CAPS is to patient experience. It's incredibly helpful. And then if I do have a condition, then the best condition-specific measure, such as the Oswestry Disability Index for spine, or the WOMAC for hip, or Oxford hip, so that the thought is when a person has a specific condition, in general, there's a third level of measurement that tailors that measurement to that person's condition or conditions. And one of the reasons to have the general measures is that so many people, as they age, have 2, 3, 4, 5 chronic problems, and you wouldn't necessarily wish to have 5 condition-specific sets of measures for them.
Anybody else on specialty?
Yeah, in general, especially for medical conditions, chronic medical conditions, asthma, COPD, where there are well-established guidelines and you can measure patient experience just like anybody else, and whether the person's treated by a specialist or they're treated by primary care or a combination of the both. One example could be that the construct of measures, let's say there's a composite related to outcomes, if that was linked to the payment and a shared interest between specialists and primary care, you would change the way they work together very quickly. And so I think the same domains could apply to specialty care as to primary care in many cases, particularly for chronic medical conditions.
Yes, and actually we are implementing things like that at United. But I was thinking specifically more about the proceduralists. So Professor Nelson showed the back one page. Feels like there's some work needed to develop equivalent ones, and I think you mentioned that there are other specialties working on that. Is that right?
Yes, that's correct.
Hi, I'm Sheridan Kassir from Partners Healthcare, and I'm inspired to ask this question because you raised practical issues. And we've been discussing a lot about quality and quality measures, but we spend very little time talking about the cost side. Partners feels like it's on a road, a little uncharted, but we have the right beacons in terms of quality. We're working with Gene on patient-reported outcomes. We have some ideas, but cost is very, very difficult. We find in our hospitals we're using antiquated systems that still allocate overhead, so we don't have a fixed view on that, to use a pun. We don't include physicians at all, so we are presenting cost data to physicians without their numbers included, which is a political problem. On the ambulatory side, we have virtually nothing at all. So I'm interested in hearing any kind of views, from health. Feel free to participate if anyone has any ideas on representing standardized costs, because we are interested in the value equation.
Sure.
Craig?
No, in our case, the only way we really have, for all the reasons you described, that getting at least expenditures is with an all-payer claims database. And it was the development of that and capturing as complete expenditure picture as we can that's allowing us to at least look at total cost of care per person as it relates to expenditures from the insurers.
So spend.
Yeah, correct.
It just adds complexity. I hate to answer by adding complexity, but I think you also need, as Kathy and others have pointed out, to look beyond healthcare costs. And I think one of the biggest challenges for the triple aim is to look at the relationship between healthcare spending and public health and social services spending. A lot of the triple aim collaborative members had similar problems, and so what they were using for surrogates were to take the largest categories of utilization of inpatient and ED utilization as a starting point to get their toe in the water for cost measurement and assuming a standard unit cost.
I do think that'll be one of for the yellow group, for the green group, for the cost group, I think the data sources and concepts are really challenging. So that group has its work cut out for it. Okay, next.
Leslie Mickelson with Prevention Institute. I'm very interested in how we deal with the complexity and not having too much data we're trying to collect. I'm actually a dietitian by training, and I'm trying to see where the dilemma I would face as a dietitian is addressed in this data collection. And so my dilemma is I've done amazing counseling with a very low-income household, and that family I'm talking to is committed to eating healthier, but they go out into a neighborhood that's filled with fast food. The school meal is really not up to par that they're eligible for. And taking Maureen's example, sure, I could try to connect that family. I should make sure they have SNAP benefits. Maybe I even connect them to emergency food that gives out fruits and vegetables. But I want a systems solution, right? And the systems solution is addressing what's in the neighborhood. It's addressing economic income. Where in the data systems we're talking about, at the healthcare, starting at the healthcare provider level, are we collecting some information that can help drive those solutions?
One of the things I alluded to was this idea of a health risk index, and we've been working with the University of Washington, Seattle to develop a health risk index that builds on the Framingham Index and adds on health behaviors like eating and exercise, et cetera. And it's based on the most thorough epidemiologic data available. And so it gives every adult, and it's limited to adults, a picture of their avoidable risk of death. and patterns of eating and of cholesterol levels, et cetera, physical activity are all in the equation. And so if I'm the patient and you're counseling me, we can start to make trade-offs. Well, you could improve your health prospects if you did this or this by this much. What can you do? How can we make that happen? But then it gets to the social factors, and so we have we're working with our Prevention Research Center grant that we have from the CDC and Population Health to do community-based programs, and one of them, for example, is to make the vending machines in the factories have healthy food choices, and to bring share programs into the factories so that healthy foods are readily available. But I think it takes these new connections into the community to get the broader impact that we need. And George's slide showing what the health partners can do versus community partnerships, that's what it's going to take.
So that's very helpful, and I'm interested in how does data collected by healthcare systems help drive those changes? And I don't think I quite get that connection quite yet.
If the incentive started to become lowering your population's health risk, and that's part of my incentive at Dartmouth Hitchcock, I start to get paid to do innovative partnerships with schools, churches, employers, et cetera.
Okay, Craig, you have something on this point.
Just really quickly, the central registry that's being developed there is also being used to collect data from some community service providers, self-management workshops. And, again, practically, once it begins to become a mature data source with reliable quality, now our Department of Health is working to bring that data in and combine it with community assessments that have been done, vital statistics data, there are a number of different registries they have, and begin to use that for their planning on some of their promotion and health and wellness programs. So it's just front edge, but you have to build the data systems first.
Okay, we have about 10 more minutes left and 3 questions, so we'll move through that and then we'll go into our breakouts. Go ahead.
So Kevin Larson from ONC, and Craig, thank you so much. I feel a strong affinity for the people that are doing this implementation. It's hard work everywhere. And the building and implementation of the measures and the standards around that is something that and many of us know the hard work. The particular thing I'm interested in here is how do we think beyond just core metrics, but also the weedy details of how will those measures actually line up and support each other. So for example, if we build cost measures around an episode of care, the weedy details are, have we defined the episode of care exactly the same as we did when we did a functional status measure? And do we find the attribution exactly the same as we did the functional status measure? And I'll tell you, from being in the middle of this, it is not like that at all now. One group developed, so they love it the way they've done attribution. They love how they've done attribution. Their episode's great, this episode's great. And so if we're eventually going to get to this place where we want to line these up into some equation, we actually not only have to pick core measures, we have to pick some core concepts and identify this is what we mean by attribution, this is what we mean by episode, this is what we mean by, and I'm so curious about your groups, how you've dealt with that or what your counsel is for us.
No, it's great points. This seems like a world that'll keep evolving. Nothing will ever be finished. And so we had to pick and are picking what organizing frameworks we can along those lines. So attribution, for instance, there's no perfect attribution algorithm for a medical home. We simply chose to adapt the one that CMS was using and see if we could get everybody to apply it consistently across the board. Interestingly, that organized incredible amount of work with the insurers. They're applying the same attribution algorithm. We're applying it within the all-payer claims database. The provider communities have come around to accepting it, even though it may not have been the ideal one for them. So there just had to be an organizing framework, and then once again, the dollars, because CMS is always the big driver, that caused a change in behavior. And I would just offer another natural experiment again is the ACOs. Those 33 measures may or may not be viewed by everybody as the most meaningful, but there's real money, and they're sitting there. People are organizing around them. So I would offer for the pragmatism of an organizing framework with incentives linked to it. I think that drives behavior.
And an argument, I think, also for the hierarchical structure of the information, that there must be a top level, that it's not condition specific, episode specific, but rather rolls up to a per capita cost, and then enables further and further and further and further drill down. But I think if we don't start with that sort of broad top level notion, we will lose.
Hi, Bela Matash, representing local health officers. The presentations, I think, represented some promising examples of integration of data across public health and healthcare, particularly Dr. Stifel's presentation. But the AAA, this paradigm actually opens up an opportunity for us to truly integrate public health with healthcare. Their overlaps are tremendous, and it's not just in the simplistic, behavioral risk factors and walkable communities. Those are very, very important, but when you think about the range of issues that public health deals with, from in-home support services to prenatal care through public health nursing, to child welfare services, to communicable disease control, there is an opportunity to truly blend the two service structures much more fully. And so I would ask us to consider in our development of metrics, even though we're breaking up into silos, ironically, to do so, that we actually consider metrics that demonstrate integration. In other words, not just this is a measure of healthcare quality for a patient with cardiovascular illness. Well, let's also show where the public health interface with that is as part of that metric. And where this can also be applied, I think, is in the cost metrics. There are costs associated, measurable costs associated with government expenditures in public health. I mean, it's much easier to get line item data for that than it is to get it out of the private sector or the healthcare industry because it's required by law. And so you can certainly cost out the different programs, the WIC program, the program for public health nursing, and then use that as base data for cost, but then also for outcome, for efficacy, use the larger population as the denominator against which you're measuring cost versus outcome.
Carl White called it healing the schism between public health and healthcare, private healthcare delivery, and it's essential. One of the hopeful experiments building on the triple aim is in the Dartmouth service area, and we're starting a program that will start this spring that would cover a geographic area and would vie to become a sustainable health system, and that the governance structure in some way would represent all of the important stakeholders in the community. It's a Rethink Health idea brought, and the triple aim brought into a specific location. And so it will take a great deal of emergent learning to make it actually work. But that is the vision, a sustainable health system that is really representative of the community's needs and interests in the social and health systems and public health systems in the community. That's beyond ACOs. I think that's the point, and it gets to the health determinants that others have been talking about as part of the measurement of looking at how the determinants of health are affecting individuals and populations.
But again, don't treat it as a dichotomy. I mean, public health is usually the environment within which mental health care and substance abuse treatment is provided. Those are your patients. You want to know about those as well. So there's direct patient care provided as well.
Exactly.
And we're involved in two in Pueblo, Colorado, and Contra Costa County, California, using the Rethink Health framework as well. And in fact, in almost all of the triple aim organizations, there's been this some faster and some slower movement toward recognition, one, that it has to be multi-stakeholder, and two, that it has to look at some broader geopolitical notion of population health.
If it's okay, let's move quickly to our last question, because we are cutting into our own time to face the challenge of getting these metric sets out there. So you have the last word.
Howard Bregman from EPIC. It seemed to me that almost all of the measures that were alluded to in the presentations were outcome measures, and there was nary a mention of process measures that I can recall. Is that an accurate assessment, and should the outcome of this workshop be that we recommend a wholesale movement away from process measures towards outcome measures?
You know, the data dictionaries that our clinicians work with us on, taking things out of guidelines, have a lot of measures in them, and they reflect the interests of different groups. And they were very interested in certain outcome measures. They were also very interested in certain process measures because they needed those, not necessarily for reporting at a national level like this, but so that they could use the results of those to guide their activities. So from the clinicians' perspectives, at least in building our core data dictionary measure set, they wanted process measures in there. They wanted to have bright futures processes built in there so the pediatricians and their teams could work and improve the care of kids, and I could go down a list of other examples. So I don't know that they're necessary for this particular conversation, but they're very important in the actual activities of panel management, population outreach, and certainly the quality improvement initiatives that each of our communities took on, and they are the ones that adopted them. So I think process measures are important at that level.
My answer, I think, would be yes, that we should start with outcome measures. But as I tried to point out in the presentation, that to build a learning system, you have to get deeper and deeper and deeper into the process measures. But I think it's important to arrive at consensus on a starting point based on outcome measures.
Okay, so in a moment, I'm going to ask you to join me in thanking our panelists. But first, just to summarize, if you're yellow, go to health in the Irvine Cove room. If your dot is black, go to the Huntington room for healthcare. And if your dot is green, go to the executive dining room for cost. Don't forget to nominate a reporter. Your charge is in the room and in your folders. Be back here at 4. And now join me in thanking our panelists. If you have questions, ask Rob or Julia, who will wave at you now so you know who they are.